In a NICU there are a lot of monitors. In my unit today, most intensive care babies have 5 to 6 screens with many signals on each screen. And try to feel how it is if you are a mother standing outside an incubator. Your precious child suffers and has a very tough way of living. And there are a lot of monitors around, beeping, giving alarm, but also giving information. So welcome to Uppsala. This is a Neonatal Intensive Care Unit. You can see its border. We have the delivery unit just 30 meters from here in this corridor. And the babies, after stabilization, they will go in this corridor and come into this door. The mother on the right, she told me, and that was something I thought very much about, that couldn't I be allowed to take away alarms, because I recognize already some second before the alarm comes that my baby will have a problem. And actually, she felt in before that the baby would have an apneic attack. So you could speculate, why is it so easy to separate the newborn baby from his or her parents? I would never be allowed to separate a newborn baby if the baby would be in the house where the parent lived, but I'm allowed to do it in the hospital. The background to our unit is that Sweden is a small country as to number of inhabitants, and our unit is internationally quite a small unit, but in Sweden it is the second largest unit. We have about 700 admittances, we have about 7,000 care days, 1,500 ventilator days, and we have about 60 to 70 babies who are born before 27th week. We have a centralized care, so most of babies are referred from regional centers to us, including neonatal surgery. We have 20 beds, and we have usually 10 to 12 in intensive care, and we have 9 family rooms. And we have about 11 physicians, neonatologists, and about 110 nurses. And our budget is about 12 million euros per year. Neonatal care has a quite short history. About 100 years ago, a neonatal unit could look like what you see on the screen. This is actually a show which is meant to trade incubators, a recent development where a French company were able to build small houses which were warm, and there they could take care of small babies and make babies survive. That were called incubators or isolates or cuveuses. That also meant a disadvantage, a big disadvantage, because the mothers of these babies were quite disturbing, and they were interpreted as being carrying infectious bugs to the babies. So they were actually not allowed to come to these incubators. So they left their babies there. That started another problem, which was that how to feed the babies. And clever people developed artificial breast milk, so-called formula, which was introduced with certain problems, but started at that time. You didn't have parents, but you had staff. The staff developed very good care routines. They became experts in taking care of small and sick babies. And they were the expert. And they even became sort of guardians of the babies. They even gave the baby names, their own names, because there were no parents there. And you can see how happy they all are and how they love the babies. In this unit we have very strict hygiene rules, and compliance to the hygiene rules is measured with the consumption of alcohol. We have hidden observations once a week, where staff appointed to this task will look the behavior of the staff as to clothing, behavior as to hand cleaning, as to alcohol use, and how they approach the patient and the parents. And then we have a registration which is put on a chart, and then we measure adherence to rules, and if it goes down we have to do some extra. But later, in the 60s and in the 70s, when I started my career, intensive care was introduced, real intensive care, by taking machines which were developed for adults and to adapt them and to use them for small babies. And you can see here is a young intensivist. He looks a bit like me, some 40 years ago. He's very happy, and he has a lot of gadgets, a lot of machines, a lot of good equipment. You hardly see a baby in that incubator. It's a very small one, and you never see a parent in that area. But this development was extremely successful, because during these decades, a very big step forward in survival of small babies occurred. So survival rate increased every decade. So there was a rapid decline of neonatal mortality, but the development also had some very severe drawbacks. In a way, I feel very bad about this picture, because this picture was actually taken in my own unit, 1976. And at that time, we didn't recognize, actually, that small babies were living humans with emotions and with pain. You couldn't see that they struggled and that they were suffering. And in a way, the development went so fast that we thought at that time that infants were actually tethered by the technology. We did interviews with parents, parent groups, parents who have had babies in our unit before. And their wishes, what we should improve in our new unit, was they would have means to be close to their own child. They wanted to be participatory, and they wanted to have influence on the care of the baby. And they would have a feeling of being very safe, and that the baby should be very safe and being cared for in a very professional and well-organized unit. And they would like to have a better and more developed communication between themselves and the staff. Today, all parents and most staff in hospitals consider that it is necessary to have parents together with the children when they are hospitalized. But is that actually true for newborn babies? Or are they hospitalized together with parents? Well, there are some good rules also from UN about the Convention of the Children's Right. They are very clear. They tell us that the child shall not be separated from her or his parents. We have also learned by psychology that attachment and bonding is a bit more than just a finger. And even if the picture to the right shows some kind of attachment, the mother or the father holding his or her baby's hand, looks very nice. It's quite a different to have skin-to-skin contact with your whole body. The baby to the skin of the mother or the father. And if you look into an intensive care unit, you might see parents now and then, and you will see that they are usually sitting on chairs. But if you look on parents sitting on a chair, you recognize that they are just visitors. Because if you put a chair, that means you can sit there for a certain amount of time, perhaps 1-2 hours. So if you could arrange the opposite, that the parents are allowed to be there all the time, that could be a possibility for participation between parent and infant. So here is a very simple graph showing what perhaps can be considered, of course, humoristically, the paradigm in an ICU. The infant is helpless. The mother is naive. And the father is useless. Could that be a paradigm? Or how do parents think about an incubator? What is their idea of an incubator if you have your baby in an incubator? Well, it is, as the name says, an isolate. It's a symbol, perhaps, of being separated. It's a very good instrument, but it is also separating. So all these facts was behind our struggles to make a change. We didn't want to have it in that way in our unit. And we struggled for many years before we could institute a change process. And our goal with the change process was, as much as possible, prevent separation between the infant and his and her parents. And within the hospital, within the unit, even if the baby was very sick, promote closeness between the baby and the parent. That could be by skin to skin, by Kangaroo mother care, and improve and implement breastfeeding. We have a breast milk bank here, which is organized by us. So we look for breast milk donators, and we prepare and check the donators as if they were blood donors. And then their milk are pasteurized, and it is sometimes added nutrients if needed, because we measure the content of nutrient in the donor milk. But most of the mothers, they are pumping, and they usually start pumping very early, some of them even before birth, in order to get access to the most valuable drops of colostrum. And it's also very good for them to feel that they can do something very important for the baby, as nutrition is always very important. So here you can see a very valuable freezer where mothers put their expressed or pumped breast milk, and it's labeled and stored and measured here by our staff. And once a day we give the baby the best milk, his own mother's milk. But a very important issue is to empower the parent in the unit to develop the parental role to become primary caregivers. Our philosophy is directed to implement family-centered care, and that means that staff tries to build partnership with families, and staff try to make changes in their own attitudes, in their own culture. And in order to achieve a change towards family-centered care, we need to have changes in leadership and changes in organization.
Är det ett måttligt underburet barn, då är det vår rutin att barnet känguruvårdas direkt efter födelsen. Om barnet föds efter 30-32 veckor. Och då kan det vara pappan eller mamman, vanligtvis pappa eftersom mamma behöver viss vård på kvinnokliniken kanske.
In our philosophy, Kangaroo mother care has a central meaning because in a way it's a red thread which could in a way influence all care routines in our unit. And the red thread is that if the baby is skin to skin to the mother or to the father, it's more difficult to separate the baby from the parent as compared to being in an incubator or in a bed. And we try to support the family, the mother's bonding and attachment to the baby. And we try to develop a philosophy where saying of the parents become very important. That means that we try to make them listen to their voice and to empower them. These dolls here, they are just to make a feeling that this is what we want the parents to adapt to carry their babies instead of putting their babies in beds, instead of putting them in incubators. This is what we think is kangaroo mother care. They are carrying the babies, and they are allowed to carry them babies around here in the corridors. They can have monitors during carriage, and usually have a monitor in the pocket, and the baby is like this, and then the baby is connected to sensors. You might think that kangaroo mother care is just something for the poor countries, the developing countries. And most research on kangaroo mother care is actually done in middle income and low income countries. But if you go and look to these reports, you can look in the Cochrane review. They have a recent meta-analysis. It's actually from this year. And interesting thing is that in this meta-analysis, kangaroo mother care instituted in hospitals will reduce mortality. That means increased survival of small babies. But in a country like Sweden, in an industrialized, high-income country, the role might be a bit different. We think that kangaroo mother care will not save many lives in Sweden, but it will prevent separation, it will empower parent, it will promote breastfeeding, and it will reduce stress in the parent and stress in the babies. And we think there is, at follow-up, there's quite good data showing that parents who have been able to live and stay in the unit and do kangaroo mother care, they feel less shame and guilt and less depressive symptoms after the care. We got the opportunity to restore the unit, and we had to use the same square meters because it was in the same building, exactly the same floors, the same walls, the same ceiling which should be used. And there were some limitations as to the building context. We had to adapt to that. And there was, as always, some limitation to the budget, and that we also have to take care of. And there was some opposition among staff and organization of the introduction of a family-centered and empowered care.
När jag började jobba här för 11 år sedan, då fick föräldrarna hålla barnet korta stunder, och det var också personalen som avgjorde när det var lämpligt. Nu har det blivit en norm att det är föräldrarna som har barnet i famnen, och att barnets vårdplats i första hand är i förälderns famn. Och att föräldrars närvaro också på avdelning har blivit ett normalt inslag.
So we started by trying to make the atmosphere and the environment quite different. It should be adapted to the need of the infants, of course, because we took care of very small babies and very sick babies, and the primary goal were to have an environment which was adapted to their needs. We wanted to make parental participation in the care possible. We wanted to improve the staff working conditions. And we wanted to have a more clever and more developed medical technology. And we wanted to give the parent more space and more privacy. And this is a main corridor for the intensive care area. And our intention is that when you will visit our unit the very first time as a parent, it should be very calm, it should look very professional, and it should not be crowded and noisy and things like that. So we prefer to have it very calm and easy, and you wouldn't suspect if you are the first-time visitors that here behind the doors we have 12 very, very sick newborn infants under intensive care. And we have 3 intensive care rooms, and in each room we have 4 cubicles, 4 intensive care areas. So this room is about 70 square meters, and it's divided in 4 cubicles. The idea is that we have everything movable here. Nothing is fixed to the wall or to the ceiling or to the floor. Everything is movable. And in each care place we have a space for the sick infant, but we also have 1 or 2 beds, adult beds for the parents. We take great care of the illumination, the source of light and the power of light, and we also take great attention to the noise level. In the middle of the room we have an area which is dedicated for the staff with monitors, and there they can work on the charts on computers. So the staff is usually centered in the room, and then they do the interventions and help actions in each cubicle. If you have to discuss and have many people attending around a topic, then we use these areas outside the rooms, but we still can supervise the patient in that area. So in this room we have facilities to do interventions on the babies who are too sick to be transported to the adult operation theater. So typically we do, for example, operation of enclosure of patent ductus arteriosus, eye operations, and some other small operations. Here we have a small area for families. With a small area for siblings, library and DVDs and things like that, which are changed all the time. And here we have a small kitchen, and here the parents can do their meals, prepare their meals, and they can cook, and they can also meet each other. They can sit down here, have meals together. They can eat here, but they can also sit here and relax some hours looking at television or films. And in summertime, we also have a small garden where they can have friends coming up, relatives, but it's also a playground area, so siblings can also be here for some hours. On strategic places we have this decibel meter, looks like an ear, and this decibel meter will change color to yellow or to red if the noise level is too high, which gives a very good feedback to the staff working in that room. The main difference in the care philosophy is that we ask the parents to be in the unit 24 hours, 7 days, all around the clock, and provide the care space for the baby. So instead of having the baby in a bed or in an incubator, the care space is provided by the father or mother or a relative. The chest of the parent will be the care space. Sometimes the babies are so sick and so unstable, so they need to be stabilized for hours or days before they can be moved to the parent's chest. And then we try to provide closeness for the family members to be very close to the bed or to the incubator. But quite soon we try to involve parents in daily care routines. And as you can see here in the pictures, we see very little staff close to the incubator or care space, and most of the care is actually provided by the parents.
Och sen successivt vartefter föräldrarna känner sig mogna och barnets tillstånd också tillåter det, så får de ju delta mer och mer. Och i princip ta över vården helt och fullt när föräldrarna känner att de är mogna att göra det. Så att det finns i princip ingenting som föräldrarna inte gör.
But of course we have a lot of staff, and staff is necessary because staff has to provide and take responsibilities for all medical care, all medical intervention, which are not trained by the parent or trained to the parent. But we try to make parents to become primary caregivers, not immediately, but stepwise, day by day, more and more responsibility.
We work more as a teacher, a guide for the parents. They don't know so much in the beginning, so they don't have that big expectation. So we just work slowly.
During the first few days, staff is more involved in helping, but a few days later the staff will be a few steps away, and the mother, in this case, will do a lot of the care routines.
They are able to do more and more things, technical things, and we take small steps all the time and encourage them. They can feed the child, they can sometimes even change the oxygen level and things like that. These medical things, but we allow it when we know that they kind of know what they're doing, and they inform us about what they're doing.
And actually, the Israeli staff which are so sensitive in performing care routines as the parents are. They are very, very skilled within a very short time. And as you can see, they are helping each other. In this case, you can see to the right that the staff is holding the intubation tube and the respiratory access tubes, whereas the parents are bathing the baby. And these parents, they are pupils in learning care procedures, but they are extremely motivated, and they are very good at it in very short time. But it's not easy. It is quite complicated, and they train and train because they are so motivated, and they become very skilled. They cup feed in this case. They are as good as staff, of course, in doing that after a while. During intervention, which are painful or hard to do, we usually put the baby to the parent in order to calm the baby and to provide security and also pain relief. It's also possible to give phototherapy, skin to skin. And you can see the baby and the parent has it good. And if you consider this picture, you will see a mother. She is not very distressed, but she is quite focused. But she is actually taking care of ventilation. She has control over the intubated baby and the tubes going to the baby. She's monitoring the baby because she can see if the baby deteriorates. She has contact with her eyes on the monitor, but she can feel if the baby stops moving, or if she can even tell us that sometimes there is a secretion in the tube. She will detect it before we will detect it by the alarms. And you can see at the same time she will provide feeding, and she will also provide warmth and humidity to the baby. And she feels empowered and she is in control. And you might wonder what she is doing here to the left, but actually she has a small mirror to inspect the face of her baby to see that the placement of the tube is correct all the time. 24/7 is quite difficult. It's a long time. The days are very, very long. The nights are even longer. But we can help to shorten them, and parents do it themselves also by reading handicraft, radio, DVDs, music, internet, and whatever. And due to a very generous family support system in our general insurance system in Sweden, also the fathers are allowed and supported to stay away from their work and to participate in the care. So usually the parent take shifts of 6 to 8 hours themselves in a shift, and then the father will take another 6-8 hours, and so they go on. Sometimes they will take a sibling or a relative to help them. And here you see a sibling. The big brother will probably be very important for his little baby sister in the future, as you can see in his expression and his careful role holding the baby. And there is a world outside the NICU also. And here is a staff incubator, and here the staff can see the sky and see the weather, because we are very close to the ground and our rooms are very dark. So we think it's very important that the staff can be half outdoors in an incubator. And outside this incubator in summertime we also have a garden. So this is a silent room, and it is closed, but if necessary, parents but also staff can go into this room for contemplation, but they can also, as you will see, take goodbye from a dead child. And there are no fixed symbols here for any religion or for any whatever philosophy you have. So the parents are allowed to do whatever they want here. They can put symbols or whatever, and then they have their babies and they can sit here and they can mourn here together with their baby and also with relatives. We promote early discharge, and we train parents to take care also at home, and we support them at home. We send out nurses with cars who do a home visit to check the baby and help the parent in different ways. And you can understand that this father or this family, after many weeks in our unit, prefer to go home and take a great responsibility taking care of this baby needing chronic oxygen therapy at home. And they manage that very good. And I will just close with some faces you probably recognize. All these faces belong to famous people, and they have been, all of them, successful in their life, but actually they were small preterms at birth. And finally, we think this was just a very first step. We have to develop much further, and we have increasing demands actually from the parents. They express more needs as to space, as to attention, as to being participatory in the care. The unit is also very attractive, so more patients are referred, and we want them to be referred because we think centralization of neonatal intensive care is good. And we have some new medical challenges coming up. We have all over the world increasing problems with infections given by multi-resistant bacteria. So what I'm actually planning at the moment is to, even if it's only 6 years since we rebuilt it, to do a new restoration or extension in order to provide single rooms concepts in a family-centered care unit. Thank you, and you're welcome, of course, to visit us.